to this deep dive. This is specifically for you, the viewers and listeners of KMR Advice.
That's right.
Today, our mission is to really get into the source material you've shared on a really fundamental class of drugs, loop diuretics.
Absolutely essential. Very powerful drugs.
We're going to follow the sequence in the material, step by step, looking at how they work, their effects, and why they're so important clinically.
And what strikes me from the sources is how targeted they are, despite, like you said, their power. We're talking about the common ones you'll definitely encounter: furosemide, torsemide.
Bumetanide too, right? And lathrinic acid.
Exactly. And the sources mention the different forms, tablets, oral solutions, and also IV anticles for injection when you need that faster action.
Okay, so how do they get to where they need to work? It's not just floating around anywhere, is it?
No, not at all. The sources highlight this really specific path. Whether you take it orally and it gets absorbed, or it's given IV and circulates quickly, it has to be actively secreted. This happens in the proximal tubule, secreted right into the tubular fluid.
So it's like a targeted delivery into the kidney's plumbing system.
Precisely. That's how it reaches the main site of action, the thick ascending limb of the loop of Henle.
Right, the loop of Henle. And this is where the core mechanism kicks in.
This is it. The sources are clear. They inhibit the NACA-2-silo cotransporter. You'll often just hear it called NKCC2.
NKCC2.
Got it. Blocking that specific transporter on the luminal membrane, the side facing the fluid. Well, that's the key step.
And blocking it means stopping the reabsorption.
Exactly. It stops the active transport of sodium, potassium, and chloride ions out of that tubular fluid, so they just stay there.
Okay, wow. So if those ions, Na, K, Cl, are trapped inside the tubule, what happens next? That must change things significantly.
Oh, absolutely. You suddenly have a much higher concentration of solutes inside the tubule lumen.
Which creates an osmotic gradient.
You got it. And the fundamental rule applies. Water follows solutes.
Water follows the salt. So because you've trapped the ions, water stays trapped in the tubule with them instead of being reabsorbed back into the body.
Precisely. The big picture, as the sources detail, is a major increase in the excretion of water, sodium, potassium, and chloride.
And there was something else mentioned too. Calcium and magnesium.
Yes, that's a really important point from the material, easy to overlook. You get this secondary loss of calcium and magnesium too. It's because disrupting that main ion transport messes with the electrical gradient needed for their passive reabsorption elsewhere.
The CalNAMP loss is definitely something to keep in mind. And all this together is why they're called high-ceiling diuretics, isn't it? Such a powerful effect on urine output.
That's exactly right. High ceiling, because they cause such a large diuresis. And it happens fast, especially IV, the sources say, within 5 minutes. Oral takes a bit longer, maybe 30 to 60 minutes.
That speed and potency, though, that immediately makes you think about potential downsides, right? Risks.
Definitely. Losing that much fluid and those specific electrolytes, well, it can lead to significant problems.
And the sources list them clearly, which is critical for KMR, advise viewers to know. Low potassium or hypokalemia, low sodium hyponatremia, the low calcium and magnesium, we mentioned hypocalcemia, hypomagnesemia, and also volume depletion like dehydration or low blood pressure.
And metabolic alkalosis, too, because of how ion exchange is affected further down the nephron. It's complex.
Which leads directly to the next crucial point from the sources, monitoring. You absolutely have to monitor patients on these.
Non-negotiable. Regular checks of serum electrolyte, potassium, sodium, calcium, magnesium, and kidney function tests are vital.
And you're also watching the patient clinically, right? Looking for signs of dehydration, checking blood pressure, monitoring kidney function.
Yeah.
Oh, and ototoxicity.
Yes, ear toxicity. Hearing loss or tinnitus. The sources link that particularly to high doses or very rapid IV administration, something to be cautious about.
So where do we actually use these drugs? What are the main clinical situations?
Well, they're real workhorses for edema that's swelling caused by excess fluid. Think heart failure, liver cirrhosis, nephrotic syndrome.
And acute pulmonary edema, fluid in the lungs.
Absolutely critical there. Also used for hypertension, high blood pressure, especially if the patient has some kidney impairment.
The sources also mentioned they can be part of treating high calcium or high potassium levels.
That's right. Hypercalcemia and hyperkalemia, they help flush out the excess ions. And in practice, simple things help too, like tracking daily urine output, monitoring body weight. That gives you a good sense of the fluid balance.
So for everyone watching KMR Advise, really getting this mechanism and the consequences down is fundamental for using these drugs safely. It's not just theory, it's patient safety.
It truly is. Understanding the why behind the monitoring is key.
We really hope this deep dive into the source material helped clarify things for your studies. If you found it useful, please do share it with your friends and colleagues.
And make sure you subscribe to KMR Advice and hit that notification bell so you don't miss our future deep dives.